right, I think we've got a good enough group to get started here. So let me welcome everyone. My name is Kelsey Berry, and I'm a faculty member at the Center for Bioethics here at Harvard Medical School. It's a pleasure for me to welcome you to the final session of the Harvard Medical School Organizational Ethics Consortium for the season. And we're jointly sponsoring this one with the Columbia Center for Clinical Medical Ethics and the Edmund and Lily Saffer Center for Ethics at Harvard. So we have a really good session for you today on how market mentality and forces are impacting the experience of medicine from on-the-ground perspectives up to the C-suite. And before we get there, though, I do want to say a kind of quick framing word about this consortium. So the Organizational Ethics Consortium here at Harvard is in its 9th year, and it's a monthly meeting that explores issues and trends in health systems that raise ethical dilemmas, or I might say more positively, ethical opportunities for healthcare organizations to do right by their constituencies and by the values that animate health. So our aim really is not just to unpack the challenges that healthcare organizations are facing, but then to look at how these organizations might navigate those challenges ethically, as we're all looking to our role in contributing to a more ethical and just health sector. So if that sounds like something that you want more of, then make sure you're on our listserv. We're going to come back in September with next year's programming. So let me just say a word about where we're going today. In some respects, today is kind of a special meeting because we're coming full circle from where the consortium started in September this year, discussing the crisis of practitioner burnout. And at the time, we were exploring solutions that were rooted in organizational commitments to health equity. But a theme that kept coming back was really just how difficult it is for organizations in today's market and regulatory environment to actually center health equity while at the same time taking care of their bottom line. And so at the risk of oversimplification, you might be able to say something like health equity doesn't pay, right? And as a result, hospitals might not pursue it or might sacrifice it, right, to some other goals. And now this kind of logic, right, that market logic is everywhere in healthcare. And we'll explore that today and how it can have corrosive effects, right, on the experience and practice of medicine. I will let our panelists share what they're observing about market medicine and the experience of it today. But just to give you a sense of where we're going, we're going to start with perspectives from clinicians and administrative leadership with the aim of getting clear about the specific forces at play before then turning to looking like what it is to ethically navigate or even change the situation. So if Ali, if you wouldn't mind placing the session objectives in the chat, no need to read them all now, but this is kind of where we're aiming today. With that, I want to welcome our incredible panelists. So I'm thrilled to have Drs. Lydia Dugdale and John Cahill joining us from the Columbia Center for Clinical Medical Ethics. Lydia directs the center and co-directs clinical ethics at New York Presbyterian Hospital and is also a professor of medicine at Columbia. And her scholarship addresses death and dying, the doctor-patient relationship, and moral injury. And Dr. John Cahill works with Lydia as a postdoctoral fellow at the center. And though he was actually locally trained here in Boston, I guess however local that is when we're all on Zoom, but to me, local, trained in Boston at Boston College in theological ethics. So as experts on physician well-being and moral injury, John and Lydia are going to take us through the reality on the ground in medicine right now. And then we're going to turn to Omar. So we're really happy to have Dr. Omar Latif returning to the consortium after his powerful remarks in the September session. And Omar, as many of you will recall, is coming to us from Chicago, where he was formerly the chief medical officer and is now the president and CEO of Rush University Medical Center and president of Rush University System for Health. So under his leadership, the medical center received national attention for how it handled the COVID-19 pandemic, and then more broadly for its strategy on health equity, despite a pretty challenging market outlook for hospitals, as you'll hear a little bit about from Omar. And then finally, we have Dr. Ian Corbin, who's joining us from Brigham and Women's Hospital, where he directs the Human Network Initiative and is a philosopher on faculty in neurology, which might be pretty unique. So Ian's philosophical work focuses on community and human flourishing, which he also expertly translates into practical advising for policymakers at state and federal levels. No small feat. And Ian's going to jump off a few minutes early to attend a committee hearing with some policymakers, so don't miss him too much. We also have Omar leaving just 2 or 3 minutes early. Don't worry, we will wrap up in enough time to hear from all of them before they go. So let me turn it over to Lydia and John now to just get us started and tell us what kind of brought you to the topic of market medicine, what you're seeing, and I'll stop sharing here.
Great. Thank you so much, Kelsey. And we're super grateful. We at Columbia are super grateful to partner with the Center for Bioethics at Harvard Medical School. Gratitude to Ian Corbin for introducing us to Kelsey and her team. And also, it's been such a delight to get to know Omar a little bit. So thank you all for organizing this, and Kelsey for your leadership. So I thought I would just bring to this discussion a little bit of framing from the practicing clinician's perspective. Yes, I'm an ethicist, but I'm a primary care doctor, and that was my entry into clinical medicine. And I still see patients as a primary care doctor. And what most medical students experience is medical school can be wonderfully humanistic. You're learning all about the body. Many of the faculty who teach medical students, this was certainly my case at UChicago, are incredibly humanistic, patient-oriented, excellent clinicians. In the examples that we're often privy to, there's a lot of time to spend with patients, and it's really inspiring. You end up doing what you think you were going to do when you started thinking about the path to medicine. And then you get through training, which is its own difficulty, and get into the real world. And my experience in the practice that I joined just out of residency had us seeing 30 patients a day. The patients were scheduled every 15 minutes. There was no interval between patients. The only interval, supposedly not scheduled, was the 1 hour between the 2 sessions, which arguably was for lunch and bathroom, but often didn't take place. And then there's no time to chart on those 30 patients during the workday. And so you end up doing that at night. And one could say, well, this is just the reality of primary care. Primary care doesn't generate revenue. We need to schedule a lot to compensate for the fact that primary care does not generate revenue, et cetera. So those arguments are on the table. But what I realized very quickly is that something was not well in the house of medicine. And my experience was that as much as I cared for my patients immensely, loved their stories, wanted to sit with them, I do a lot of end-of-life stuff, as Kelsey said. I love being with my patients. There was no time to be. There was no time to handhold. There was no time to hear their stories. In fact, I quickly figured out how to use body language to signal that we needed to keep moving. And then I figured out the kind of language to use verbally to signal that we needed to keep moving. I realized that to make it through 30 patients in one day, I needed to, in a sense, not be a human being. That everything I'd been trained to do there was no time for it. And it wasn't that time is something we throw around, but isn't, is really just an excuse. There truly was no time. The analogy I like to give to people is, let's say you have a friend in distress and you want to meet that friend. You don't give your friend 15 minutes, at the least you give your friend an hour. If I have a medical student in distress, I don't give my medical student 15 minutes. At the least, I give them 30, 45 minutes, if not an hour. So being human takes time and energy, and primary care, my experience is not structured for it. And then I started asking other questions early on. Well, maybe it's me, except that I felt that I still cared immensely. I felt well supported. I had great community, great marriage, healthy kids, which I don't take for granted. And then I would read Tate Shanafelt's stuff, the burnout researcher from Stanford. formerly at Mayo. And, Shanafelt defines physician burnout as a work-related syndrome involving emotional exhaustion. And I would say I wasn't emotionally exhausted. I was physically exhausted. Depersonalization, but that wasn't my experience either. And a sense of reduced personal accomplishment. And I'd get to the end of a workday and I'd say, I saw 30 people. I cared for 30 people, maybe not well enough, but I took care of human beings in need. This is an accomplishment. So the language of burnout did not resonate, and yet something still felt wholly wrong. And that's when in 2018, I came across the language of moral injury when it made its foray into medicine for the first time. And so I'm going to stop now and turn it over to John, and he can talk to you a little bit about moral injury and sort of how we have developed that line of academic work. Thank you.
Thanks, Lydia, and thank you, Kelsey, and the rest of your team. It's wonderful to be involved in this conversation and with everybody here. So we've been doing some work on moral injury, and our understanding of moral injury is that it's the trauma that results from constraints on acting in ways that accord with deeply held beliefs. So it's either something that you are involved with or something that you are witness to, and it's involved with constraints on keeping you from being able to act in the way that you want to do. Oftentimes, there's a rupture of your moral identity. Who you see yourself as is somehow affected because of what you're doing or what you're unable to do. So the question is, what do we do about this? I'm not a clinician, Lydia is, and so I'll step back and think a little bit about that. The first focus on well-being and physicians really began in the 2000s, where there was more of an acknowledgement of the moral distress and the burnout that many clinicians were feeling. And the focus was primarily the individual. How do we help these clinicians to have the tools to build resilience, to have the practices, whether meditating or something different like that, to be able to maneuver through these difficult circumstances? These are really good and important, but they seem to miss something. They seem to put the problem in the individual patient, that there's a deficiency right there. So there was more of a shift at the beginning of the 2010s towards the institutional and organizational systems that affect that. So what are the administrative burdens or the workplace logistics that can be addressed to improve the experience of clinicians? Lately, what's happening and what we would argue for is if one was micro level, and then the sociologists would say the meso level, the organizational, what is the macro level's role in situating these organizations and individuals? And what is that role in the moral injury and burnout that's being experienced? And in many ways, this is actually returned to the initial ways that moral injury was discussed. In the early 1990s was the first time that term was used by Jonathan Shea. He coined the term, and it was with Vietnam veterans that were returning from war, and they had been involved or they'd witnessed these actions and felt this shame and this guilt. And Jonathan Shea really saw this as moral injury. He was very specific in that language. It's not a disorder. It's something that has happened. And in many ways, in the words of Joseph Winnicott-Leiden, there's an inherent moral critique, a political critique in that. And that should not be taken away and decontextualized from those circumstances. So in many ways, that's what we are trying to do, is we're trying to look at moral injury within the political context and see that as a call for us to address that political context. So the political context that we're in now that has affected healthcare, as we've been talking about, is this market logic. I think that a term that we could use is neoliberalism. It's a contested term, but has to do with characteristics of confidence in the power of free market to bring about the best economic systems, emphasis on deregulation, privatization, individual responsibility. So that's the work that Lydia and I have been doing. We're trying to develop some thoughts on this. So very briefly, how does moral injury connect with this market logic? Well, the alienation that can come from one's work, that can come when the pursuit of profit becomes the means of improving healthcare. So according to this line of thought, a free market that is in a competitive environment will bring about the best quality care and the lowest prices. The market will do its work. And the pursuit of profit becomes not just an intention with the care of patients, but becomes the means to the care of patients. And I think that can result in alienation in clinicians. There's also the betrayal that comes from the responsibility being pushed from organizations and governments down to the individuals without reciprocity. The clinician is being asked to do more and more to invest in themselves. And if they fail, well, who's responsible? The individual. And that can be experienced as betrayal. And the normalizing of inequality and the stress that comes from complicity in such situations. The inequality is normalized. It is just part of the natural way that market works. And as we are more aware of the social determinants of health, we see this tension as there's a complicity in the healthcare systems that we are participating in. So in many ways, this is difficult because when you move, if the individual is easier than the organizational level, when you move to the macro level, it's even much more difficult to try to even thinking about changing. But we think it's really important to be understanding the political situation, social situation that our organizations are embedded in as a first step towards addressing moral injury. You're muted, Kelsey.
Sorry about that. So thank you so much, John and Lydia. You know, what I'm hearing from you is kind of this profound sense of loss, right? That there's something amiss or broken in the house of medicine, the experience of medicine, and that this relates, you know, fairly directly, not only to the organizational constraints, right, within which practitioners exist, but the broader kind of macro constraints. And I wanted to pick up on something, John, that you said before we invite Omar, which is about the notion of the pursuit of profits, right, as a core element of the political circumstance and market society in which we exist. And, you know, there's about, I think it's now almost 60% of hospitals in the United States are not for profit. You know, and so there might be some questions here. What's going on? Like, is it the pursuit of profits? Is it an effort to survive financially so as to continue to exist and serve a mission? But nonetheless, that still calls in a lot of the kind of market principles or business efficiencies, right? That, you know, that might need to be in place in order to facilitate that financial survival. And it's kind of on that note that I want to bring in Omar to help us understand, you know, what's kind of going on a macro level and, you know, as a leadership at a nonprofit institution, what you're seeing, right, in your experience and how that impacts the delivery and organization of healthcare in your setting.
Thanks for having me, and thanks for putting me on a panel to represent the economic financial realities of healthcare in America. It's a very easy, straightforward subject of which I have no formal training for. I'm a pulmonary critical care physician by training, who trained in New York in internal medicine and then came to Chicago and did my fellowship at Rush, and came into my job working as, you know, eventually the ICU director or a program director, and really enjoyed education. I woke up one day thinking that there has to be a better way to make healthcare work in this country, and then started to try to get involved in some of the administrative efforts, and went on a journey to where I am now, which I wouldn't call a happy journey, but a journey to try to make an impact or try to make a difference. The learning for me was it seemed a lot easier when I was on the other side, just rounding in the ICU of all the things that needed to be done in healthcare that I could just fix if I had a chance, to when I had the job. And when I had the job and realized all the different challenges and nuances to it, largely wake up overwhelmed by the reality of healthcare today in America. And so I've said this before, I'm not sure if I said it in this forum, but we've used terms like market competition and nonprofit. And I think they're very important to put in perspective around healthcare. Because when we talk about capitalism in America, that means like if I open a store and I sell donuts and the donuts are fantastic and they're at a lower price, that store will do well. If I open a store and overpriced donuts and they taste terrible, no one will go buy those donuts. In healthcare today, profit is not designed by the outcomes you have. You can have the #1 predicted mortality in America and the best patient experience and lose money every year. And you can have amongst the worst outcomes in America and just happen to be in an area that has a high payer mix and do really well. And so what I would tell you is that the normal rules of market dynamics and capitalism don't apply to healthcare. They absolutely don't. And the way I would explain this to you is by saying it's one-sided capitalism. The costs in healthcare over the last 20 years, since when many, and I'll just use 20 as an example because many people on this call started practicing healthcare 20 years ago. A reimbursement for an appendectomy was X and the cost for doing it was Y. Every year over the last 20 years, the cost for doing it has gone up. Beds are more expensive, IV tubing is more expensive, medications are more expensive. The reimbursement that's set not by us, but by external forces, the government and payers, has gone down out of the last 19 of those years. So I don't know another industry in the world where the costs go up, but the reimbursements have gone down and the market has gone down than in healthcare in America. I can't explain it. And then we talk about how healthcare is a human right, and it is a human right. It's a human right when someone comes to your door after they've been shot in inner city Chicago. It's not a human right when you need a vaccination that will prevent long-term cost of care. So we have a misalignment in our resources in this country, and we have a misalignment in how we're paying for healthcare overall. So one is the immediate resources. Two is the conceptual understanding of, well, it's basic economics, just because the economic model doesn't apply to healthcare because we have to treat everybody. Now, that said, I've never met a healthcare provider in my entire life that didn't want to treat the people in front of them. I have never met a doctor. I have never met a nurse. I've never met a pharmacist that wanted to offer less care. Never. And so the pressures that are put on healthcare are not at the fault of the providers. They're at the fault of the reality of having to break even. The idea of being a nonprofit was just brought up. And then everybody talks about how there's this machine that's trying to generate profits. Every year, there's new equipment that needs to be purchased in a hospital, like an MRI machine. Every year, there's new modalities that need to be invested in. There's new service lines with new technology. There's a magnet that you can try to knock a tremor out by putting it against a brain that we have to figure out how to use. It costs $4.5 million. A nonprofit simply reinvests the profits that are there for their mission and what they're doing. They're not taking it out and spinning it off and sending it to shareholders. Research is incredibly expensive in healthcare, and it's the innovative engine that made US healthcare phenomenal for the last 100 years and some of the innovations that have come out of healthcare. All of that money is the money that's generated by the workflow inside a hospital. And unlike the rest of healthcare in America, where margins are very high, margins in healthcare facilities are very low. And in the nonprofit world, about 60% of hospitals this year are below zero on an operating margin. They're losing money. And about 30 to 40% are even making as much as 1%. 20 cents out of every dollar in this country goes to healthcare in some capacity. 20 cents. 4 of those goes to providers. There's many of you on this call that are far more economically advanced than me. I don't know how I get on calls like this. I'm not qualified and I'm not intelligent. But I can tell you that if 4 cents goes to providers, 16 cents goes to the ethos of healthcare outside, the burden of correcting this can't just be alone on the 4 cents. The burden of relieving the moral injury that people are facing can't just be on the people that are already losing money or below zero on an operating margin. That has to be a shared burden that we as a general society have to be able to take on the question and the real challenges. Is healthcare a human right? If it's a human right, change the model, right? It's very easy to sit outside and hate. It's very challenging to go inside. When I transitioned from being the person that loved rounding, I loved it. I loved the greatest job in the world. You got to save somebody's life. It was the greatest job in the world working as a critical care doctor to the worst thing that can happen when I do a night shift now is taking a shower and putting a suit on. Because the minute you walk into that door, you become the tip of the spear of hatred, of trying to reverse a trend that an individual healthcare system has no resources to reverse. So I think the challenges are far more extensive and complicated than just the ability of a single fragmented healthcare infrastructure to try to solve. We instead have to figure out how to unfragment and come together as a nation and decide what's valuable.
Omar, thank you so much. I wonder if you could say just a little bit more, because you've described the reality of a number of hospitals being, below zero in their operating margin, a really challenging financial outlook, and what the nature is of that reality for the kinds of choices that need to be made in the kind of leadership of those organizations that may connect to some of the experiences Lydia and John are talking about. Can you kind of draw a little bit more of a line to the financial pressure that exists to the on-the-ground experience through the choices that present themselves and are made?
So the more good that you do in healthcare, the lower your operating margin is. So we talk about things like disparate outcomes. So it's far more lucrative today to write a paper on inequity and present it at Harvard and Stanford and Yale than it is to try to solve inequity. It is far more lucrative to take a picture of a disease and talk about it and get all the glory that comes with discovery than to try to solve it. Healthcare institutions are trying to solve it. So we have a 3 times higher mortality in Black and brown people in this country from COVID-19. At Rush, we said, that's not cool. Like, we're not going to do that. And so we made the strategic decision at the beginning of the pandemic to take patients from all the safety net hospitals in the city, and we were going to reverse that mortality. It was part of our mission. Many of you probably have never heard of Rush. We're a very humble hospital, but we founded something called the Anchor Network. We created something called Westside United, which crowdsourced resources to try to change the community. But the reality is, we said we were going to reverse the death gap. In the city of Chicago, if you're born on Michigan Avenue, you live 16 years longer than if you're born in the neighborhood of Rush. 16 years, 5 subway blocks. So now we can all sit in a room and talk about reversing that. But the reality is, there is funding that exists to show that a new disease has different outcomes based on ethnicity. But if you want to change it, if you want to reverse the higher mortality in breast cancer in Black women versus white women, you put a breast cancer screening center in that neighborhood that needs it. That neighborhood cannot pay the overhead for the cost of care. It can't. So the minute you make the decision to decrease that death gap, you're simultaneously making the decision to lose revenue. So now when you're sitting there trying to run a hospital and you're a board, you're a fiduciary board, or you're a leadership team, and these are the rules of what you're practicing, you have to decide, all right, this is our mission, this is what we're going to do. Now is the time to double down. So during the pandemic, Rush made the decision to take transfers. We took 1,000 in the first surge, 1,000. And to get into Rush, you had to almost be dead, you had to need ECMO, and you had to be either uninsured or undocumented. That is not a great business model. And as a result, my first year as CEO, I learned about words like debt covenant, bond holding ceilings, things that no doctor should ever have to understand. Right, but I learned all these words because we lost $250 million at the end of the first year. So your question, how do you make decisions when you're running healthcare? Well, it's really easy when you're in the ICU because you want to take the overdose that you can put on ECMO and know you'll save their lives. And so we do. And so does every doctor I've ever met and every nurse I've ever met. They want to take that patient. Right. The frustration is, how do you pay for it? Like, the resources aren't there to pay for it. And so that creates the friction in the decision-making of where you're going to invest. And some of the most profitable hospitals, in my view, are very good at having that discipline around where they're going to invest and not invest. I'm not going to be the CEO in 2 or 3 years because at some point I'll get fired because I'll lose that balance.
Let's bring Ian in on this. I think that in some ways, understanding the nature of the market environment within which we exist, or the way that hospital healthcare finance works, it might seem like it requires something like a PhD in health policy, although Omar, you just said, that's not what you had when you walked in the door. But nonetheless, I wouldn't be surprised if for some of you, the complexity and detail of financing kind of makes your head spin. And so what I wanted to do is just bring in Ian, and maybe I'm putting you in a tough position, Ian, but to kind of connect us in a way to some of the ethics, right, or the underlying moral considerations that are relevant when we think about the, the challenge that our present arrangement puts us in. Ian.
Thank you, Kelsey. Thank you, and thanks to my fellow panelists. I would say that, it can make the head spin, these considerations that Omar's laying out. I would also say that I don't feel particularly a great sense of agency when I hear about how things are arranged. And when I hear from, when I first started at the hospital at HMS, I went to New York to give a talk at a very prestigious surgery hospital that is the main provider for orthopedic surgery for all the major sports teams in the area. And I thought, well, this is an extremely powerful institution. I was spending time with the head of the hospital. I thought this is a very powerful man. But the story I heard from him was that their hospital was under deep threat, and that he felt quite sort of threatened by the market forces around them, that they would get gobbled up by a larger system, that they got out of business. And this is a sentiment I've repeatedly heard from people who ostensibly are in positions of great influence and leadership in the world of medicine, that there seem to be sort of forces operating outside of our control that are really driving, the way that medicine happens. And they're driving it in lots of ways that I think providers and patients aren't happy with, right? And just to step back a little bit, this is an odd situation because here we find ourselves, in one of the richest societies that has ever existed. And it's our society, right? We make it up. And we're in possession of the most sophisticated medical training and medical instruments that have ever, existed on the face of the earth. And yet somehow we don't seem able to craft this practice into something that we're happy with, right? We seem like we're constrained by forces, right? Even more than people, by forces, right? So Omar talks about, costs rising, vendors are charging more, machines are more expensive, insurance companies are reimbursing less. And in all these cases, you look around for who to blame. And again, you might have a hard time because a lot, these economic and these market actors are acting according to what we take to be a kind of ironclad mechanistic logic, right? That companies who operate in the market do so to maximize profits, right? And they will release their wares, they'll give their services when they feel that the highest possible price has been achieved, right? So they'll charge as much as the market will bear. And we accept that as more or less just how the world works. This is actually a very odd way to organize exchange. It's a very odd way to organize a society. So I've been reading the past year or two, trying to think through this, through some economic historians and some anthropologists like Carl Polanyi, Marshall Solins, David Graeber. And what they say is that the idea that economic actors and economic action exists like outside of our sort of systems of value, our morality, our religious values, our philosophical values, is a modern invention, right? That prior to about the 19th century, it would have seemed absurd to most human societies to say that, well, we as a society want this, right? Or we as a religious group want this. But economic, as economic actors, we're not sort of part of that moral story, right? Like we're operating according to a separate logic, right? That's become disembedded from our sort of deep moral intuitions and our deep moral desires. And what Polanyi says is that by separating society and market in that way, you don't actually end up with two separate tracks, the way that the sort of 19th century economic theorists suggested we should and would. Instead, he says you end up with a market society, right, where the imperative to maximize profits ends up being the sort of governing system that, inside which all these other activities now take place, whether they're religious, whether it's provision of medical care, whatever it is, that we're all sort of operating now inside this market frame. And, operating inside this frame over the past 150 years, 200 years, has in some ways been incredibly productive, right? Like, we have technologies, we have facilities that earlier generations could not have imagined, right? They would have been delighted to see what we're capable of. In terms of acute care, I live in the Boston area, and when when my children have been very sick from time to time, I'm so happy that I'm in this system, that I'm near these facilities. Infant mortality has fallen to being basically a rounding error in places like Boston, whereas it used to be a massive thing, right? That we couldn't get our hands around. So in lots of ways, existing within this market framework has been dynamic and it's been productive. But good as it is, good as it's been for these sort of technological advances, for these sort of acute cases, I think there's a real question whether having a market society and market medicine is overall good for our health, right? And whether these systems are actually making us healthier year over year. In my lifetime and all of yours, and actually since we began to collect statistics on it, life expectancy in the United States has risen every year until the past about 10 years, I think. Don't quote me on that, but until quite recently. And the reason why life expectancy has stopped rising in America is the rise of what are called deaths of despair, right? So these are deaths from drug overdose, from alcohol poisoning, from ruining your liver, and from suicide. Right, so our life expectancy is now going down. And the two economists at Princeton, Angus Case and Ann Deaton, nope, flip those around, Angus Deaton and Ann Case, have they've argued that actually, like, our system of healthcare and how expensive it is and how difficult that can make it for people to hire and retain workers is a lot of what's at ground level driving the rise in deaths of despair, because it's sort of hollowing out communities, it's pulling the economic base out from under people, and when that happens, whole lives fall apart, right? Whole ways of life fall apart. So as dynamic and exciting as these advances in healthcare have been, and as much as market society has done for us in lots of ways, I would suggest, or at least want to ask, whether this is a framework, an approach to sort of organizing our common life that we really want to retain and work within and tweak as best we're able and push for little policy changes as best we're able, or whether, to keep going as a happy, healthy, functioning society and to take care of each other, to take care of our sick. It's time for something a little more fundamental in terms of rethinking this model of a market society and market medicine.
Thanks, Ian. So I want to open this up a little bit to just some conversation between all of our panelists before, or even as part of looking towards solutions. What I might kind of highlight actually to begin with, and I'll invite folks to comment on this or something else that they're thinking about. As Ian said, we probably shouldn't be that surprised, right, about the nature of the market forces that are constraining what we want to be doing with our healthcare system. If we've accepted healthcare as something of a market commodity and more broadly a market society within which we exist, then it's not that surprising to be buoyed by the dynamics that come with that. But that if we're upset with the way that it's landed in our lives, right, we ought to be willing and able to push back against that kind of a mentality. But we haven't said a lot, right, about what we would replace it with. And I'm not asking for a description of an alternate economic system or just an alternate system, but rather a little bit of thinking about what are the nature of the values, right, or the commitments that ought to be animating the practice and organization of healthcare, and the attitudes, right, that come along with that, around which we might think of building an alternate way of organizing our system. Service, love, care, are these the kinds of things we're thinking of? So I'm going to push that out there as to say we've done a little bit of the critique, right? If there are thoughts about the other side of the coin, what we're aiming for, I want to invite folks to think that through. No need to do that in this moment. Let me instead, Lydia, you came off mute. I think you've got some thoughts. Please go ahead.
Yeah, no, I kind of wanted to pick up on several of these threads. And I think it's interesting that you are pushing us to think about the values that might guide. I wonder more about the nature of the institution itself. So what is healthcare? Is healthcare something like, is it a consumer entity? That's the way it plays out in America right now, as everybody's been saying. Ian said nicely. Is it more like a charity, in which case we need mass philanthropy to fund it? Is it more like a school where you get a basic level of education, K through 12? What is the nature of healthcare? And I think then we can sort of start to think about, are there other models that make sense? But I'll just say in an earlier life, I went to business school and with a bunch of docs, and our professor, we were sort of pushing back. Can healthcare be something else? We think there are these different values. And our professor said, this is what the American people have voted for. we have had the opportunity at different points in history to create different systems, and Americans want their options. They want to be able to shop for things, et cetera, et cetera. And so are we trapped by that, or can we imagine a different nature for healthcare? And so I'm kind of throwing that question out.
I guess one thing is maybe tying both what Kelsey said and Lydia said is that I think part of the switch that we've had, if you look from the middle of the 20th century, was much more of a focus on the common good and that we are all in this together, and with a much more focus now on the individual and the individual's responsibility. So I think there's like this, if we have a society that moves more towards that idea that we're all in this together and we need to be working together, then that would be one value that would move you to there. Because the individual, it's okay, each person has their responsibility. They need to be able to do what they can in life to be able to get that good care. And I think that that's also where you get into that loneliness that comes out that Ian was talking about, the depths of despair.
Yeah, I mean, I think there's a, your professor has a point, or at least historically has had a point that, most Americans, for various quite specific historical reasons, have accepted that this just is the way societies function, right? That like, hey, sorry, this is how the world works. And a lot of, there was quite an amazing coup for neoliberal economists in the second half of the 20th century and onward to say that I'm just telling you objectively how science works, right? I'm telling you how money moves around, full stop. And so, you disagree with me, sorry, you just disagree with reality itself. That's obviously, well, it's obvious to me, I think, and not true, that there's a lot of moral sort of judgment that's taking place under the surface there. But I think this is, maybe paradoxically, one reason for hope. That the meeting that I've got to run to right after this is with some elected officials, and the topic of the meeting is the fact that, again, in this historically wealthy situation, in the situation of sort of falling crime rates in America, and a lot seemingly going really well, we have massive levels of loneliness and alienation, plummeting levels of trust in institutions and in one another. We have, a majority of adolescents and young adults reporting that they feel no sense of purpose in their lives. So I think that, as much as a lot of this stuff does seem common sense to people, I think there's increasing room to make a really serious and persuasive counter argument, because I think a lot of people are feeling hollowed out, feeling that society is hollowed out. So again, that's sad, that's bad stuff, but maybe also, is a door cracking open a little bit to be able to make a counter proposal.
Now, I wonder, and Ian, you're being kind of the resident researcher on human connection and belonging. I mean, Lydia raised this open question for us, which is to say, what is healthcare, right? How can we think of it in different models, from commodity to charity to something more like a school-based model? And it's not entirely clear to me that even if we feel hollowed out by the way it is now, that we have a good sense as to what it rather ought to be conceived of, right? And so in some respects, there's a way in which our present existence, right, in kind of this experience of a loss of belonging, maybe rising inequality, as John pointed out, as a consequence of some of the way that we set up our society, makes it really hard for us to come together in some kind of robust civic conversation about what we think healthcare ought to be or how it ought to be designed. And so I'm curious, from your perspective about what would be needed, right, to create the foundation for some kind of constructive reimagining of these systems that are so central to our well-being, but that nonetheless seem to be moving in directions which don't serve the values that we think that ought to be part of them. So that's kind of a question for you, Ian. And I know, Omar, I think you have a lot to say, but I also wanted to just ask you to come in a little bit too, in thinking about how you keep mission central in your work, because in some ways it seems like that's pushing back against some of the dynamics, right, that we're raising as a concern here. So I want to kind of tee you up for that, but in the meantime, bring it back to Ian. What would we need to do this kind of collective work in reimagining these systems?
Yeah, I mean, I think this experience of feeling sort of abandoned and isolated, and like you live in a really go it alone society, up front, it often manifests in kind of unhealthy ways, right? The sort of like intense tribalism that we're seeing right now, a lot of like pretty radical demonization happening across the political aisle. I think one thing that we as kind of thinkers with platforms can do is we can push for a deeper and better understanding, and just say, hey, you know how you feel like X, Y, and Z? Well, I mean, I think maybe it might be more about these deeper conditions, right? Or you know, you look across the aisle and see these sort of ravening monsters of your political opponents. Like, well, they probably also are feeling quite lonely and sort of scared and precarious in our sort of society. And so just sort of naming at least the way things are now. And I don't think, look, there's not like, you know, you don't need to sort of immerse yourself in the ethical theories of Kant or Aristotle or anyone to talk about how things would be better, right? Like, I think most Americans just would like to see the sick taken care of, right? Like, would like to see people treated well and fairly. And so, to me, I think a lot of it is just sort of, you know, Margaret Thatcher was fond of saying that there's no alternative to this system. A lot of it is just to point out that, like, you know, the way we're doing things is hurting us, and there are alternatives. That's at least it's an early step to try to hopefully galvanize you know, a new kind of framework.
Omar, do you want to jump in a little bit? What are your thoughts on the challenge, or at least how if you do feel you're able to like bring forward the mission, right, or if your organization against or in tension with the underlying concerns for margin or financial health?
You know, if we took a group of people that were involved in the healthcare ecosystem, insurance companies, there were some people talking about insurance companies, we took the technology companies, we took all the different people that are taking money out of the healthcare world, and we redistribute that in a simplistic way, we could probably all figure out, many of you are 100 times smarter than me, can figure out a way to take that net amount of money, spend half as much, and offer a better product. I don't think there's any debate across the spectrum of doing that. It starts, though, to even have that conversation with having the sort of bold and audacious goal of deciding what our true north as a country is going to be around healthcare. And without doing that, I'm not sure how you get stakeholders in a room and agree that venture capital can't take out 19x profits, or private equity can't take out 6x profits, or insurance companies can't make billions of dollars during a pandemic when 1,000 hospitals will go out of business. I think we are misdirecting a lot of the rage in this country routinely, and I think we're polarized. And if a pandemic, you know, I heard one of my colleagues, Jonathan, say that, you know, we have to be in this together. And that's a phrase that causes great pain in me personally, because during the pandemic, I would see companies say we're in this together while simultaneously suing us for not paying them for IV tubing. So it's hard for me to sit here with this perception of we're in this together as a nation when we haven't decided what the overall view of healthcare is. Like, we haven't come out and said it. No entity of the government has said healthcare is a human right and all people get antibiotics the minute they need them. That vaccines are available to all people immediately. Like, that's not there. During the pandemic, it was there for a minute. We paid for COVID-19 vaccines. And then somewhere along the line, I think there's a lot of lessons in the pandemic. We learned how polarizing the views of healthcare are, because not everybody actually believed we needed a vaccine, and not everybody believed that we should be giving vaccines. And so I think what came out of that was the disparate perceptions of what healthcare is and what healthcare should do. It's not a lack of trust in one or two people. People may hate Omar Latif or the CEO of United Healthcare or the CEO of Blue Cross Blue Shield. But before we figure out who we're mad at and who we're not, I would argue that we should sit down and decide what we want to be. And once we decide what we want to be, this is a healthcare system that we expect this country, then let's put the pieces together to do it. Because right now, there's a lot of different people in a lot of different parts of this industry trying to succeed within the rules that exist today. And that creates the hyper fragmentation. That's why the one thing we never talked about during the pandemic was We did a great job showing the salacious pictures with ICUs being overrun and bodies being put where there was no more morgue space. But we didn't go 60 miles down the street and show an empty ICU. As a nation, we did not load balance. As a country today, we are not taking advantage of the resources we have. And so it takes a broader footprint and courage to take a step back and say, the system we have is, I don't know that we could tinker with the knobs that exist right now, because that's what I try to do every day. And there'll be just a shit ton of criticism about how we're not doing it well enough. But I would say that those knobs are never going to move the dial that so many of you are experiencing pain around. You're on this call because, and this is a bit of an echo chamber. Like we're in an echo chamber of people that agree that we have to, like, healthcare is valuable and a human right. I'm not convinced that 70 million people would agree with us. I think there's 70 million people that may disagree that it's a human right now. I don't know, but I think it takes, a broader step back to define what the true north is before we start figuring out how to get there.
So I think in the kind of spirit of thinking about where we go from here, I want to also invite some questions and thoughts from the attendees present today. Just to kind of bring a little bit of framing, as Omar is alluding to, there's a lot of knob twiddling within the system as it exists. And maybe that's not going to bring the kind of fundamental change that is in order, right? But at the same time, right, we can have two ideas about what the nature of solutions might be. One of them is wave my magic wand, right, and generate a system that meets the values, that ought to be the true north. Another is to say, how do we ethically navigate this situation as it exists, right? And those two things can be going on at the same time, working towards a different approach, while at the same time being transparent, for example, about the limitations that exist and explaining why it is that certain decisions have to be made, and letting that be part of our ethical action in the context of a less than perfect situation. So I want to invite the panelists and perhaps even the audience members, as you think through your questions, to consider what are some of the things that you would look to practitioners or organizations to do to navigate the situation as it stands ethically. And then, are there values or true norths that you think ought to be held out as part of resistance and movement towards a different kind of reality? So I've just asked a lot. For folks who want to ask questions, please go ahead and raise your hand using that Zoom function. We'll keep a queue. But maybe I can just start with the panelists if you wanted to say something on the topic of solutions or moving forward.
Sure. So I'm really interested in the macro questions, which is why I was super excited to do this panel. But I will just say, as a practitioner, my approach, drawing on some of what you just said, Kelsey, is to be super transparent with my patients. And what I always say to my medical students is, make an alliance with your patient, in a sense, against the system. Not that we want to throw the system under the bus because we need the system, but if I'm honest with my patients, like, I'm under the same constraints that you are, or slightly different constraints, but both of us are constrained. And so then we need to work within the constraints of the system to get your health as good as possible. And I'll do the best I can to support you in that and not abandon you in that. That's sort of the language that I've adopted. So there's an immediate transparency with the person in front of me to whom I have committed my working life, but also help them understand that, yeah, the way that primary care is scheduled is this. And so we have this amount of time. Come in with your list. Let's go. Let's sit down and nail it together, because you and I are constrained by the same clock, in a sense, and that can take different forms across the system. So I think we can't, what are those values? Transparency, honesty, authenticity, vulnerability. I think there's a certain vulnerability, non-abandonment, really critical in a system that I always say primary care is designed to get people to quit. We just be honest about that, and then figure out how we can ally together to the best that we can to make it through. But that still doesn't solve these bigger picture questions. So I'll turn it over to the rest of my colleagues for those answers.
Omar and maybe Lydia, I'm curious, do you see any role here for modified forms of corporate governance, for maybe like labor organizing among doctors, or really are the obstacles outside the ken of the people who are pulling the levers and making the decisions at the top of the hospital systems? Like maybe we organize and we push and we demand better conditions for treating patients, and maybe CEOs just say, good, I want it too, but my hands are tied.
Guys, there's a fixed amount of money in a healthcare system. That fixed amount of money has decreased every year for the last 10, 15 years. The expectation of what's provided by everybody in that system has increased every year over the last 10 or 15 years, and that would have an increased cost. There's an illusion that high executive salaries are the driving factors of this. High executive salaries don't even amount to 1 day's cash on hand for a hospital. If you did away with all that, we're talking about billions of dollars. The cost of the electronic medical record, the cost of the infrastructure we have to deal with insurance companies, far outweighs all of those sort of costs inside the system. And there's no impact of the ability of the provider to make a change. Ask yourself why the last time you flew across the country, you were able to do it without talking to a person. You downloaded an app on your phone, you figured out how to do it, you bought your ticket, you changed your flight, you figured out it was incredibly efficient. You were able to show your phone everywhere, even in the parking garage at the airport. It got you your spot, you knew where to go, you got your Uber when you were there, you got your hotel, you did your entire trip without seeing a person. And compare that to the last time you went to a doctor's appointment. During your last doctor's appointment, you gave your birthday 3 times. You filled out your paperwork before you went in, and then when you went in, someone actually took a picture of your insurance card and photocopied it. The last time you saw anyone do that, it didn't exist anywhere else. That is actually there because of the incredible amount of inefficiency built into the system. It's not built into that system because a doctor wants to be inefficient. It's built into that system because of the outside forces that are mandating the way that we're forced to practice today. I'm not making excuses. I'm trying as hard as I know how to do to fight those systems. But there is an electronic medical record that dictates what we do, and everything has to work on that electronic medical record. They can set a cost for whatever they want that cost to be. That's great business. They're somehow insulated from any criticism. But the nurses and doctors and providers in this world that are working day and night are somehow carrying the burden of fixing the entire system. It's not going to be fixed from within the healthcare system, from within a hospital system alone. It's just not. And I want to be really clear, not every hospital system is the same. While the criticisms towards health systems are the same, health systems are very different. They all have very unique cultures, and they all have different levels of endowments. Some healthcare systems have $50 billion in endowments sitting in a fund, right, and have the ability to help drive change, and others have 2 days cash on hand. Yet they're held to the same rubrics. And I think we have to be very sincere in understanding that they're not all the same. 2, that solutions aren't going to come from healthcare systems. But to get right at what you said, Ian, these outside forces have to be called out. Like, they have to be brought to the conversation. Like, it's great that there's $1 trillion electronic medical record companies that exist out there. It's great that supply chain companies are going to hit the $1 trillion mark at some point. I don't know. We got a less than between 0 and 1% margin in healthcare on average in America. Perhaps that should be balanced out. So yes, there's outside forces.
So pick up the idea of organization, organizing. Sometimes I think it's easier to take a step back from our current situation and look at a previous situation. In the early 20th century, late 19th century, there's some striking similarities to today. The market was driving healthcare as a place that was ripe for making profit. And there's a lot of distrust among patients towards the healthcare because of this idea of making profit. And in the early 20th century, there was a pretty big shift where the profession became much more prestigious and respected. And there's a good book by Peter Swenson called Disorder. You can't really see it there, I guess, but A History of Reform, Reaction, and Money in American Medicine. He says that the American Medical Association is actually a big part of that change. And that is different than the typical narrative of the AMA in the 20th century, which tends to be thought of more as looking at their own autonomy and searching for ways for their own self-interest. But in that first decades, they had a big emphasis on reforming the drug industry. They wanted to try to get a cabinet level department that was doing federal research on public health issues. They were endorsing compulsory health insurance and reforming medical education. And in that period, Swenson attributes that to a lot of the cultural prestige. There was a big change in the 1920s to the AMA, but during this period right there. So our situation is very different, but I think this idea we could pull out, one, that it is important for physicians to see essential to medicine is addressing some of these social issues and advocating for patients on this way. Secondly, that collective action is really important. As an individual, we can't do any kind of change. So we need to be working together, and even working with other people can bring some moral repair, knowing that you're working on the same objective with other people. And then prioritizing the patients and their well-being. Sometimes in organized, we can very easily look in on ourselves and what is our working conditions like, and that's good, and it's connected with the patient's well-being, but making sure that that stays at the front. That's where we're really going to build trust. And as we work together, I think that's our biggest hope of eventually making some kind of change.
Can I test an idea on my panelists, my fellow panelists? And John, this riffs on what you're just saying and ties to the conversation. So someone else at business school many moons ago said, and this guy I thought would be totally hardcore capitalist, for-profit, everything. And that's just the way I read him. And I asked him what he thought about healthcare, and he said, well, it seems to me that if we live in the richest country on earth, everybody should get a little bit of healthcare for free. And I wasn't expecting that from him. But I think the analogy there might be that, and I don't think he would even use the language of healthcare as a human right. But just as all children get a K through 12 education in this country, it might not be great, might not have the finest facilities, but they learn to read and write and count. Maybe everyone should get very basic healthcare. And then the question becomes, how could that be realized? And so just sitting here, I'm wondering, I did some of my training at a veterans hospital. What would it look like to have a true two-tier system where we expand, say, the veterans hospitals to include Medicare and Medicaid? There would have to be very deliberate expansions, but there would be a basic level of healthcare provided to all people. And then we think about, well, do you expand Medicaid further, expand Medicare? Is it Medicare for all? Is it Medicare for, all those questions are on the table. That doesn't take away from the sort of aggressive for-profit entities, but it does go a certain distance to trying to make sure that all have access to basic healthcare. I don't know. Does that, Omar, I'm looking at you particularly, but any of my fellow panelists, Ian, does that idea even have any chance at all, or no?
Ian, you're at Harvard. I'm not. This is all you.
Do you mean politically, Lydia? Do we have a chance at that politically?
Well, I think that's ultimately going to be the biggest impediment, right, to realizing some sort of, because it'll immediately be branded as you're going for single payer. We're anti-single payer in this country. You're going to threaten the pharma industry. You're going to threaten the supply chain industry. You're going to threaten insurance companies, right? So maybe politically it's not viable, but I just am wondering about both how we meet this very human need that we've committed our lives to, and how, is there any prayer for realizing it? Because it didn't all collapse in COVID. In fact, some people got richer. So what would an alternative model look like?
Yeah, I think there are a number of models that seem to be working for other countries in other parts of the world. The one that you described, the two-tier, that's a fairly moderate step. If you take a socialist Jew from Vermont and you run him for president, he runs into some trouble sometimes. If you take his policies, and we know this, if you take his policies one by one, you remove them, you delabel them, and you march them through the American South, they're actually quite popular. So I think that, we're held back from making some of these sensible, humane reforms, less by the unpopularity of the reforms themselves and more by the sort of like really ossified tribes we put ourselves in. And again, I think that there's a lot of upheaval politically right now. And I don't know what the next election or the next couple of elections are going to hold, because a lot of things have gotten scrambled recently. Because I think things have just gotten so extreme that a lot of people are asking big evaluative questions. So yeah, I mean, I personally am hopeful. I think these sorts of common sense, humane ideas might be more popular than and more politically plausible than we realize.
I think that's actually a good place to bring in a question from the audience. Katie, you were raising something in the chat. Do you want to go ahead and ask our panelists or raise it?
Sure, thank you. And I apologize, I missed the first 30 minutes. I'm sure it were amazing comments, but actually it builds off of something that Omar and Lydia and Ian just said about K through 12 education and things being popular if you delabel them, and just to get to the core of the policy. And I guess I do think that we're in an echo chamber, and I think even when we're not in an echo chamber, people will agree with us. We're talking with adults who I frankly just don't have a lot of faith in adults, including myself, because we're fairly entrenched in what we think. And so I guess I was just curious if anyone on the panel knows of any kind of efforts between kind of either clinical leaders or hospital kind of business leaders and students to try to have these conversations, getting back to what Omar was talking about in terms of society needing to decide what they think about healthcare, whether they value it, what they think it is, and just having these conversations with children, even like first graders, but also, high school students, et cetera. There's this democracy knowledge project based out of Harvard, but, it teaches in Cambridge, and that's not really where it's needed. And so, anyway, I guess I was just curious. I realize that children are also not in silos, right? Children are raised by their parents, and so we also instill our own values in them. But I was just curious if this conversation could be broadened a little bit to include the next generation.
I mean, I can speak. Well, I can speak about my experience with college students who are not quite children, but I think I'm fond of telling the politicians that I interact with that there's a sort of generational time bomb ticking, because actually, almost to a person in my experience, college students and the college students I teach are at very privileged institutions, and they're set up to do really well in our society as it's currently constituted, and almost to a person. They're very cynical about our current system, and they think and they're checked out, and they think it's totally ass backwards and bad. So I absolutely think that there's a big generational shift that it hasn't showed up fully, I think, in the sort of polling that we do. But yeah, I think that's one of the reasons why I'm hopeful, because I do think we're on the cusp of something. We're in one of those historical periods where the paradigm we've been working with seems to have run out of gas, and we don't yet know. We haven't really named the next paradigm yet, but I do think a lot of people, young people, there is a generational difference, but let's say especially young people are feeling ready for some big reevaluation.
Yeah, I would echo that. I think that, look, if a crisis can pull us together and defragment healthcare, if an actual crisis where people are actually dying, it's still somehow controversial. That makes me less optimistic about yesterday. What makes me more optimistic about tomorrow is that when you meet students today, they're hungering for solutions and to be part of the solve. We need less vitriol and more dialogue around the actual issues and what they are, and we have to start pulling people together. And what I really mean about an echo chamber is you can get in a room, especially around people interested in healthcare and certainly around ethics, and talk about whether or not migrants should get a measles vaccine to prevent an outbreak and who should pay for that. Nobody's going to argue we should pay for that. We should just go figure out how to get vaccinations. But there are millions and millions of people in this country that do not want to pay for that vaccination today as we sit here. And so that's why I said it's important to take a step back and decide fundamentally, what is the problem that we're trying to solve? Like, what is a fundamental health problem that this country wants to solve? It's not, we have people that are in favor of the Affordable Care Act, but don't like Obamacare. Like on interviews, right? Like we have reporters going and capturing. So it's not about the facts. We have to like disregard all the names, and we have to disregard all the brands. We have to take a step back and say, what is a problem that we're trying to solve in this country in healthcare? And then once we do that, I have every confidence in the world that we can solve that problem. We're great in the face of crisis as a nation, and in healthcare institutions, we have historically stepped up. So I think the reality is we have to decide it's time to do that, and this is the direction we're going to go. And that decision comes from leadership and voices. And where I completely agree with Ian is young voices are so much more sincere. Kids are so much more sincere. Younger adults are so much more sincere. The older you get, the more broken you get. And the more in healthcare you are in this space, the more cynical you can become. And it's hard to sort of prove that outside of just me. Like, it's hard to say, like, here you're in your basement working out on a treadmill, and you see a commercial with someone saying we're in it together, and the next day they're filing a lawsuit against you because you're not paying them, during a pandemic, and you're using that money to take care of uninsured people. So I think as a nation, we have to be clear on the problems we're trying to solve.
I do want to bring us, so as an organizational ethics consortium, right, I think that we want to understand the macro drivers that place organizations within the constraints that they face. But at the same time, so in that respect, recognizing that organizations are not all powerful, right? But at the same time, also seeing organizations at this kind of meso level as another place for the kinds of work that we're describing as happening at a national level, right? So what role might hospitals and healthcare institutions play in convening people around discussions? And I think this is picking up a little bit on Katie's question, around discussions on what ought to be the North Star. So I'm curious, with respect to organizations that have a mission, right, that are not for profit and exist not for the purpose of making money, but for the purpose of their mission in community benefit and care. Are there instances in which there can be mission discernment going on, right? Not just internally at the organization, but together with the communities that are ostensibly being served, right, by that mission. Is this, a kind of open question as to whether A, you think that would be a good thing, and then B, whether it's the kind of thing that ought to be asked of healthcare organizations and hospital systems, is to do this kind of mission discernment work with people who might have diverse ideas about what that mission ought to be.
Omar, I feel like this is you, actually. Can you comment? Or, I mean, I have a friend who was hired at a hospital that shall remain nameless, that is a Catholic hospital, and he was hired to, as sort of guarder of the mission. He was supposed to safeguard the mission of the institution, because the institution is now being run by MBA business types. And the institution, I guess the board felt that it was really important that there be someone who understood the mission and basically championed the mission. But I also hear Omar saying he's trying to champion the mission and he may not have a job in a couple of years. So I see a real tension there of trying to hold on to a mission and also keep the lights on, and also buy that magnet that you implant for $4.5 million.
Yeah, so this question and comment could be the subject of another 3 hours. We can just sit and talk. And, we've all discussed, you're brilliant people on this call, and you don't have to sort of clarify margin versus mission. Rush is a pretty unique place, and we think it's pretty special. Everybody who works here comes here because they believe in what we're trying to do. We're going to try to we're decreasing the death gap by half by 2030. we put a basketball court in the most violent zip code in America, and that basketball court will save more lives than our ECMO circuits. I can't prove that that's value added to our value-based care strategy. We put homeless people in hotels that were COVID positive. That decreased the net cost of lung transplantation down the road for everybody, right? But it net came out of one institution. No one institution is going to solve healthcare's challenges today. We're all going to make steps, and institutions are going to make some type of impacts in their community benefit programs and what they're trying to do. The reality is that we're very fragmented in it. But the question is to safeguarding a mission. You have to safeguard your overall facility so that you can do some mission. Because if all you do is provide care everywhere that you need it, you'll go bankrupt. And look, at the end of the day, it has to pay for itself. It has to pay for its operations. That's the difference of what happened to me when I switched from being that CMO and then change your clothes and then walk into or when I changed from being the ICU doctor to sort of walking into the office. How do you balance all those confounding pressures? I think that for the most part, it's really easy to sit back and say, well, no one's doing enough. But the decision has to be clear. You have to know what you're trying to do. And at Rush, we can all speak to what we're trying to do. We have board approval for it. Our front line approves it. We know this is who we want to be, and this is the kind of organization we're going to run. This is our goal, and this is our true north. And as long as we stay on that until we're really in bad shape, we'll change. But we proved it during the pandemic when we made the strategic decision to live our values. And we're paying for it now, right? But it's okay. We're still okay. Like, we're still surviving somehow. But that margin was a lot easier in 1990 when hospitals were at 20% margins, in 2000 when they were at 10% margin, in 2010 when they were at 5% margins. Now we're between 0 and 1%, right? And that's why you're seeing all these hospitals with all these cuts go out. So when you do that, right, when you're at an inflection point about survival, you tend to keep some programs, but you may invest less in your community. You may invest less in your social program. I don't know how else to answer it by being blatantly honest.
Omar, I hear like you saying that the hospitals are all in competition. We're talking about this market logic that we're having.
Yeah.
So it's more almost a need for the hospitals somehow to be coming together and working together. Have you ever seen that, or is there a path forward for that?
Yeah, I want to be really, really clear on this. Not only, look, if an international pandemic couldn't bring healthcare together permanently, like for a sustainable period of time, we have a problem. So you remember a couple of years before COVID, when the Ebola outbreak happened in the United States, there was, I think, a total of 4 patients that actually had Ebola that were here. I think 1 at NIH, 1 in Houston, and 2 in Nebraska. And they were brought in. But every city that had a major airport was worried that they were going to have Ebola patients. And you know what happened? Ebola units, makeshift units, Tyvek was acquired by everybody as fast as they can get in. We started running out of all the material. We had 4 patients in this country, and we had community hospitals 30 miles outside of Chicago that had more Tyvek than us, right? We're a complex critical care hospital. We didn't have resources. So then when we said, so we tried to get all the hospitals together and say, let's just have a shared call schedule. When they come into O'Hare, one person will take them, and why don't we just use one facility? Because we happen to have a room like this here and we can all share. The decision was made, well, we can't do that because then people are going to think we don't have an Ebola unit or we're not going to try to help. It's not just fragmentation competition. It has to do with ego. It has to do with finances. It has to do with like where you have to offer these services. But did we really need in Chicago 4 hospitals willing to take an Ebola patient that no one believed we would ever get one? Did we really need hospitals in Minnesota to have this? Did we really need hospitals in Michigan to have this? So when I was a chief resident and admissions would come in, I had a sheet of paper, like, and I could just say, the next one go to this team, the next one go to this team, the next one go to this team. So we made sure everybody had the same number so no one team got unfairly hit with really sick patients. And Katie, you remember this from residency? Lydia, you remember this from residency? You had these patients and we all shared. The minute we graduated, we didn't. Now, when COVID happened, there were hospitals that could do ECMO. and some did 9 and others did 0, right? But if the city of Chicago functioned as a chief resident and each hospital functioned as a floor of one hospital, we would have saved more lives. And we built that in Chicago, but we didn't get it running till the 3rd surge when we didn't need it anymore, right? But when the 1st surge came, but now fast forward to today, it fell apart. So the level of fragmentation, it's because of the greater design. We're competing against patients, and there's no other environment worse than that than the one where most of you are sitting in, which is in Boston. You have cutting edge heart programs on every corner, but a person can't get a cardiology appointment in that city. You have cutting edge rheumatology programs in every corner, but it's a 6-month wait to see a rheumatologist, but yet they're all fighting for patients. So to me, it's figuring out how to load balance, not just Ebola, but cardiac disease, because we have experts that can see patients that aren't seeing the patients they need. We have pediatricians that know how to prevent a disease from being a lifelong challenge with a conversation that don't have access to the right patients. I don't think I answered any question there, but I feel pretty good.
With just a few minutes remaining, so the kind of thematically, and I want to give each of the remaining panelists a moment to wrap up anything that they want to offer as we leave today. But I do just want to say thematically, talking about the role of collective action, collaboration, solidarity, right? Some of these really big ideas, each one of those brings its own ethical challenges. In the COVID-19 pandemic, as hospitals, some of which did figure out how to do patient transfers and in that sense share resources between them when there were capacity issues at any one individual hospital, there were a lot of particular ethical issues that arose in the context of arranging a system like that. And this is actually one of the topics of an earlier consortium of ours in thinking about how do you actually coordinate as individual institutions in attempting to meet a public health goal and a public health threat. So I'm dropping that in the chat for people who are interested, but it's just, I think, a call in a way to those on the call today who see themselves as being involved in identifying the morality or the moral or ethical dimensions of some of these issues, is to say it might sound really big picture now, but if you put yourself into the framework of saying, how am I going to help facilitate something like a collaborative effort towards defining what it is we ought to do as a health system? How am I going to help us think about sharing resources or doing things together rather independently and competitively? There are a lot of ethical questions that come up in the course of actually implementing those things. And I would invite you all to actually dig deep into the specifics of doing them. So 5 minutes left. Let me offer it back to Lydia, John, and Omar. Maybe Omar first, because I know you've got to jump. Is there anything that you want to leave us with today, having chatted about this situation?
I would just say that having these conversations is more meaningful than I think people realize. I think having these conversations and then having it transmit to a broader audience and having honest dialogue about what are the problems we're trying to solve is the direction we have to go. There is incredible brilliance in school today. There are young people with the desire to change the world. And I think that as long as we foster that and work towards doing what's right, we'll be okay. But I do think that this concept of moral injury to me is tragic and scary. And it's heavy-hearted, and I dread some of these conversations, knowing that I'm going to be the kind of the tip of the spear of being perceived as the bigger system. I think that collectively we have to work together to try to solve the problem and focus on solutions. So truly appreciate your time, and happy to, if any of you want to reach out to answer any questions in the future. Thank you.
Thank you, Omar. Have a good afternoon out there. Lydia, John.
I would just say, for those experiencing distress or injury, don't give up hope. Find other people who are in the same boat as you. Don't try to do it alone. Find community. And if you look back at the last century, there's been some radical changes in the economic system, and sometimes it happens quickly. So there's a lot of entrenched interests that are going to be fighting against that. But I think there's still hope that a better future is ahead.
Yeah, thanks, John. And I think drawing on this idea of sort of togetherness, which is what's core to a lot of Ian Corbin's work as well, figuring out how to cultivate relationships now with the institutions in your vicinity, such that when the crisis hits, those relationships of trust are intact, and then things like sharing patients and resources becomes a natural sort of a natural use of the network of authentic relationships that have already been built. And so I've been really challenged by Omar in that regard to think about how we can reach across institutions, building relationships in non-crisis periods that we can then depend upon when the going gets tough. So thanks again, Kelsey, for hosting this time together.
Well, thank you so much. We really appreciate the time that you spent. This has been a year's worth of effort, I know, and has far more tendrils to unfurl from today's conversation. So just from the perspective of the Organizational Ethics Consortium, I really want to thank each of you, and I'll send this to Omar and Ian as well, who had to run, for modeling, I think, the kind of dialogue that we would hope could exist in a number of different spaces between folks who have clearly different standpoints, right? From the clinical on the ground experience to leadership roles in the quote business of medicine, to ethicists who are existing, you know, in academic and research spaces. It's really, I think, a model for how we might actually make this kind of progress, and recognizing that this consortium is a space for that to happen, I think, is one of the reasons that I hope you will continue to come back to it, and also to raise up issues that you hope we can model this kind of dialogue around as well. So thank you all. Have a wonderful spring. We hope to see you again in September, and a round of applause for our fantastic panelists.